Bismillahirrahmanirrahim. I welcome you all to this session on amoebiasis. By the end of this session, all the participants should know the following: what is amoebiasis, the burden of disease related to amoebiasis, epidemiological determinants, mode of transmission and incubation period, and finally, prevention and control of amoebiasis. The term amoebiasis has been defined by the World Health Organization as the condition of harboring the protozoan parasite Entamoeba histolytica with or without clinical manifestations. The symptomatic disease occurs in less than 10% of the infected individuals. The symptomatic group has been further subdivided into intestinal and extraintestinal amoebiasis. Only a small percentage of those having intestinal infection will develop invasive amoebiasis. The intestinal disease varies from mild abdominal discomfort and diarrhea to acute fulminating dysentery. Extraintestinal amoebiasis includes involvement of liver, which may cause liver abscess, lungs, brain, spleen, skin, etc. Amoebiasis is a potentially lethal disease. It carries substantial morbidity and mortality. As far as the burden of disease is concerned, if we talk about the world as a whole, amoebiasis is a common infection of the human gastrointestinal tract. It has a worldwide distribution. It is a major health problem in the whole of China, Southeast Asia, and West Asia, and Latin America, especially Mexico. Globally, it is estimated that 50 million, more than 50 million people carry Entamoeba histolytica in their intestinal tract, and approximately 1/10 of infected people suffer from invasive amoebiasis. It is probable that invasive amoebiasis accounted for about 100,000 deaths in the world. Prevalence rates vary from as low as 2% to 60% or more in areas devoid of sanitation. In areas of high prevalence, amoebiasis occurs in endemic forms as a result of high levels of transmission and constant reinfection. Epidemic waterborne infections can occur if there is heavy contamination of drinking water supply. In developing countries, it is generally agreed that amoebiasis affects about 15% of the population. Amoebiasis has been reported in many developing countries, and the prevalence rate of about 15%, ranging from 3.6 to 47.4% in different areas, has been seen. The reported variations in prevalence are attributed to variations in clinical diagnostic criteria and to technical difficulties in establishing a correct diagnosis and lack of sampling criteria. Now I'll be discussing with you the epidemiological determinants, and as all of you know, we use the model of the epidemiological triad in which we have the agent, host, and environment. First of all, I'll discuss with you the agent factors. As far as the agent is concerned, amoebiasis is caused by potentially pathogenic strains of Entamoeba histolytica. Recent studies have shown that Entamoeba histolytica can be differentiated into at least 18 zymodemes. A zymodeme is a population of organisms differing from similar population in the electrophoretic mobilities of one or more enzymes. It has furthermore been shown that pathogenic strains are all from particular zymodymes, that non-invasive strains are from quite distinct zymodymes, and that invasive strains can give rise to fecal cysts, and the organisms breed uh, uh, through these cysts. As far as Entamoeba histolytica is concerned, it exists in two forms. One is the vegetative, which is called trophozoite, and the other is the cystic form. The trophozoites dwell in the colon where they multiply and encyst. The cysts are excreted in stool. Ingested cysts release trophozoites which colonize the large intestine. Some trophozoites invade the bowel and cause ulceration, mainly in the cecum and descending colon. Then, in the rectum and sigmoid, some may enter a vein and reach the liver and other organs. The trophozoites are short lived outside the human body. They are not important in the transmission of the disease. In contrast, the cysts are infective to man and remain viable and infective for several days in feces, water, sewage, and soil in the presence of moisture and low temperature. The cysts are not affected by chlorine in the amounts normally used in water purification, but they are readily killed if dried, heated to about 55 degrees centigrade or frozen. As far as the reservoir of infection is concerned, man is the only reservoir of infection. The immediate source of infection is the feces containing the cysts. Most individuals infected with E. histolytica remain symptom free and are healthy carriers of the parasite. The carriers can discharge up to a large number of cysts daily. The greatest risk is associated with carriers engaged in the preparation and handling of food. As far as the period of communicability is concerned, as long as cysts are excreted, the period may be several years if cases are unrecognized and untreated. Now I move forward to the host factors. Amoebiasis may occur at any age. There is no sex or racial difference in the occurrence of the disease. Amoebiasis is frequently a household infection. When an individual in a family is infected, others in the family may also be affected, and specific anti-amoebic antibodies are produced when tissue invasion takes place. There is strong evidence that cell mediated immunity plays an important part in controlling the recurrence of invasive amoebiasis. Now I further move to the environmental factors. Amoebiasis is more closely related to poor sanitation and socioeconomic status than to climate. The use of night soil for agricultural purposes favors the spread of the disease. In countries with marked wet, dry seasons, infection rates are higher during rains, presumably since cysts may survive longer and the potential for transmission is thereby increased. Epidemic outbreaks are usually associated with sewage seepage into water supply. Now, I've already discussed with you the agent factors, the host factors, and the environmental factors. Now, I will be discussing with you the mode of transmission. As far as the mode of transmission is concerned, the first is the fecal-oral route. This may readily take place through intake of contaminated water or food. Epidemic waterborne infections can occur if there is heavy contamination of drinking water supply. Vegetables, especially those eaten raw from fields irrigated with sewage polluted water, can readily convey infection. Viable cysts have been found on the hands and under fingernails. This may lead to direct hand to mouth transmission. The second is sexual transmission, which is by oral rectal contact, is also recognized, especially among male homosexuals. Then, transmission is through vectors such as flies, cockroaches, and rodents are capable of carrying cysts and contaminating food and drink. As far as the incubation period is concerned, it is about 2 to 4 weeks or longer. Prevention of any disease is very important. And as I quote that Chinese proverb that prevention is better than cure. As far as amoebiasis is concerned, I'll discuss with you primary prevention, and the measures aimed at primary prevention center around preventing contamination of water, food, vegetables, and fruits with human feces. The first is sanitation. Safe disposal of human excreta coupled with the elementary sanitary practice of washing hands after defecation and before eating is a crucial factor in the prevention and control of amoebiasis. But there are too many hurdles, both social and economic, in enforcing it in many developing countries. It is only with the cooperation of the local community that the sanitary systems should be selected and constructed, taking into consideration the customs and practices of the population and the available resources. As far as water supply is concerned, the protection of water supplies against fecal contamination is equally important because amoebic cysts may survive for several days and weeks in water. The cysts are not killed by chlorine in amounts used for water disinfection. Sand filters are quite effective in removing amoebic cysts. Therefore, water filtration and boiling are more effective than chemical treatment of water against amoebiasis. As far as food hygiene is concerned, environmental measures should also include the protection of food and drink against fecal contamination. Uncooked vegetables and fruits can be disinfected with aqueous solution of acetic acid, which should be around 5 to 10%, or full strength vinegar. In most instances, through washing with detergents and running water will remove amoebic cysts from fruits and vegetables. Since food handlers are major transmitters of amoebiasis, they should be periodically examined, treated, and educated in food hygiene practices such as hand washing. Finally, the important component of primary prevention is health education. In the long term, a great deal can be accomplished through health education of the public. At the end of this session, I have also shared with you an animated video regarding dysentery, and that I think is one of the very good health education tools, especially in the communities. Now I come to secondary prevention. As far as secondary prevention in amoebiasis is concerned, demonstration of trophozoite containing red cells is diagnostic. They are most readily seen in fresh mucus passed per rectum. Microscopy should be performed immediately before its schooling results. The absence of pus cells in the stool may be helpful in the differential diagnosis with shigellosis. Serological tests are often negative in intestinal amoebiasis, but if positive, they provide a clue to extraintestinal amoebiasis. Indirect heme agglutination test is regarded as the most sensitive serological test. Newer techniques include counter immunoelectrophoresis and ELISA technique. As far as the treatment of amoebiasis is concerned, we have symptomatic cases at the health center level. Symptomatic cases can be treated effectively with metronidazole orally, and the clinical response in 48 hours may confirm the suspected diagnosis. The dose is 30 milligram per kg of body weight per day divided into 3 doses after meals for 8 to 10 days. Tinidazole can be used instead of metronidazole. Suspected cases of liver abscess should be referred to the nearest hospital. As far as asymptomatic infections are concerned, in an endemic area, the consensus is not to treat such persons because the probability of reinfection is very high. They may, however, be treated if the carrier is a food handler. In endemic areas, they are always likely to be treated. They should be treated with uh, oral preparations, and of course, the oral preparation which should be used should be diodo hydroxyquin, 650 milligram 3 times a day in adults and 30 to 40 milligram per kg of body weight per day in children for 20 days, or oral uh, diloxamide furoate 500 milligrams thrice a day for 10 days in case of adults. At present, there is no acceptable chemoprophylaxis for amoebiasis, and mass examination and treatment cannot be considered a solution for the control of amoebiasis. With this, I end today's session. The video which I am sharing with you will also cover a lot of things in addition to my lecture.
Today's topic is dysentery. Dysentery is an intestinal inflammation, primarily in the colon. It can lead to mild or severe stomach cramps and severe diarrhea with mucus or blood in the feces. Without adequate hydration, it can be fatal. Each year worldwide, there are between 120 million and 165 million cases of Shigella infection, of which 1 million are fatal. Over 60% of these fatalities are children under 5 years old in developing countries. Causes: Shigellosis and amoebic dysentery typically result from poor sanitation. This refers to environments where people who don't have dysentery come into contact with fecal matter from people who do have dysentery. This contact may be through contaminated food, contaminated water, and other drinks, poor hand washing by infected people, swimming in contaminated water, such as lakes or pools, physical contact. Signs and symptoms. The main symptom of dysentery is frequent near-liquid diarrhea, flecked with blood, mucus, or pus. Other symptoms include sudden onset of high fever and chills, abdominal pain, cramps and bloating, flatulence, as in passing gas, urgency to pass stool, feeling of complete emptying, loss of appetite, weight loss, headache, fatigue, vomiting, dehydration. Diagnosis. Besides conducting a physical exam and reviewing your medications, your doctor might order tests to determine what's causing your diarrhea. They include blood test. A complete blood count test can help determine what's causing your diarrhea. Stool test. Your doctor might recommend a stool test to determine whether a bacterium or parasite is causing your diarrhea. Flexible sigmoidoscopy or colonoscopy. Your doctor might recommend one of these procedures to look at the lining of your colon and provide biopsies if no cause is evident for persistent diarrhea. You should note any travels outside of the country. This information can help your doctor narrow down the possible cause of your symptoms. Treatment. Laboratory results will reveal whether the infection is due to Shigella or Entamoeba histolica infection. If treatment is necessary, it will depend on these results. However, any patient with diarrhea or vomiting should drink plenty of fluids to prevent dehydration. If they are unable to drink, or if diarrhea and vomiting are profuse, intravenous or IV fluid replacement may be necessary. The patient will be placed on a drip and monitored. Treatment for mild bacillary dysentery. Mild bacillary dysentery, the kind commonly found in developed countries with good sanitation, will normally resolve without treatment. However, the patient should drink plenty of fluids. In more severe cases, antibiotic drugs are available. Treatment for amoebic dysentery. Amoebicidal medications are used to treat Entamoeba histolica. This will ensure that the amoeba does not survive inside the body after symptoms have resolved. If lab results are unclear, the patient may be given a combination of antibiotic and amoebicidal medications, depending on how severe their symptoms are. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated.
With this, I end today's session. I hope you have clearly understood what is Entamoeba histolytica, what is the total burden of disease, what are the epidemiological determinants as far as the agent factors are concerned, the host factors are concerned, and the environmental factors are concerned, the mode of transmission, as I mentioned in my lecture, fecal-oral route through sexual transmission, especially in male homosexuals, and through vectors such as flies, cockroaches, and rodents. Then I discussed with you about the incubation period, which is about 2 to 4 weeks or longer. And finally, I discussed with you the prevention and control, in which I discussed the primary prevention and I addressed things like sanitation, water supply, food hygiene, health education, and secondary prevention, in which I discussed with you early diagnosis and treatment. My email address is there on the title slide, and if you have any questions, you are most welcome to ask, and I will be glad to answer your questions. Thank you. Allah Hafiz, and take care.